The National Consortium for the Study of Terrorism and Responses to the Sirens found that our 35,000 people were injured and 28 killed in our 11,000 bursts of firearm-related terrorist attacks worldwide. Much of our current understanding on how to treat these injuries has came from the lessons learned during military conflicts and terrorist attacks. As seen in several epidemiologic studies worldwide, the extremities are most commonly injured, while 65% of these injuries are soft tissue injuries that may be treated as an outpatient. They frequently have devastating orthopedic-related injuries that can require urgent surgical management due to the degree of the soft tissue damage or bone loss. When evaluating penetrating ballistic wound on the battlefield or in the hospital setting, the amount of energy transferred at the time of injury must be considered in order to avoid understanding the corresponding zone of injury. The degree of energy imparted on the superficial and deep soft tissue is often a surrogate of the weapon of type of offending agent. The degree of injury can often be understood due to small visible entrance wounds despite devastating underlying soft tissue or bone injury. As such, clinical assessment must be focused on determining the degree of contamination, contaminate abdominal injury of bowel perforation, possible vascular injury, type of weapon, whether high velocity or lower velocity, and proximity of the blast region, as this will dictate operative and reconstructive measures. In those injuries require operative intervention, definitive bone reconstruction cannot begin until there is healthy tissue bed. This may require temporary skeletal stabilization, but will centrally require throughout excision of all highly contaminated and non-valuable tissue. Furthermore, in those penetrating injuries where the zone of injury is not immediately apparent, repeated assessment in the operating threat with future tissue excisions.
ग्रुप नंबर रख बेटा
6:30.
Special attention should also be
मेरी
paid.
सहेली क्या
नाइस माला
अब कोई माइक ऑफ करो अपना।
हेलो गाइस हेलो ए सौरभ भाई ग्रुप में हेलो आ रहा हेलो आ रहा हेलो आ रहा
यस माला
आ रहा
माला माला
आ रहा
यस माला यस। अरे सर कॉन्फ्रेंस में है भाई, माइक ऑफ करो।
आ रहा माइक
Special attention should also
केपी जेवायला ये
related abdominal and pelvic injuries, where the projective process genital viscera. These injuries are the higher risk of requiring repeated surgical treatment or systematic antibiotics due to bowel content contamination, a fracture site or joint. Retrospective studies have shown up to 4 times higher infections rate when a bowel injury has occurred from a gunshot wound and concomitant fractures. Periarticular injuries often have severe cartilage loss and or bone defects that can complicate the final reconstructive options due to the need of the abdominal bone or implant augmentation. Interarticular fragment Particular injuries often have several cartilage loss or bony defects that they can complete the final reconstructive options due to the need for additional bone or implant augmented. Interarticular fragments should be excised either arthroscopically or throughout and arthrotomy, or if required, in order to damage the likelihood of plumbism and the mechanical effects of the cartilage surfaces. A higher rate of vascular injuries have been seen in battlefield, blunt, and penetrating extremities trauma. These injuries often play a vital role of determining the role of damage control, orthopedic principles, and final reconstructive options. If immediate definitive vascular repair is not feasible, temporary shooting with a reconstructive option. With a Javid or axial shunt can be placed, restore distal blood flow. The repairs often require the addition of a temporary external fixation placed during the initial operative intervention in order to protect the vascular repair. This can subsequently be converted to definitive fixation where vascular repair has been deemed successful. Alternatively, if definitive fixation can occur expeditiously, tibial intramedullary nailing and the bone and soft tissue injuries of mediable, it can occur immediately prior of vascular reconstruction. Ballistic and blast injuries are often associated with a critical bone loss. This is a definite smallest defect and specific bone which does not heal spontaneously, which is often 4-3 times and diameter of the involved bone. The defects will frequently require various temporary stabilization techniques by bony and soft tissue augment and our contamination, nerve, and vascular reconstruction. As such, these devastating injuries require a multidisciplinary approach associated with a prolonged treatment course and often fraught with complication. Ultimately, the patient must understand that acute treatment course and the subsequent recovery process is not linear and that there are often late anticipated complication. It is important that this is discussed early to assist with managing the patient's expectations to that they can be to recognize that their recovery may have a long protective course. Immediate assessment and care, pre-hospital. Immediate pre-hospital care should consist of patient stabilization and transportation onto an appropriately equipped medical treatment facility. Initial focus should be on saving life and normally following ballistic trauma. This is focused on controlling hemorrhage. The role of splinting in the pre-hospital settings cannot be understated, as they can prevent additional tissue damage and bleeding while assisting with the pain control. There should be a low threshold for pelvic stabilization with an appropriate binder. If the patient has been close to an explosive or is in clinical suspicion of a pelvic fracture, repeatedly plead non-circumferential temporary splints and non-invasive extremity tractions should be considered in unstable fractures. Per terms, the immediate use systematic antibiotics is open fracture is mandatory. Imagine upon arrival to the hospital, appropriate trauma and life support guidelines should be initiated to appropriately evaluate and treat the patient to include pelvic imaging. Ideally, if there is suspicion of a pelvic injury, CT imaging should be performed. If initial imaging occurs when a pelvic binder is in situ and is negative, it should be reparated when the patient is stable. When the patient is stable following pelvic binder removal. In the setting of extremity ballistic and blast injuries, the entire extremity to include the joints above the level of injury should be fully imaged in Gonal plans using plain radiography. Penetrating wounds should be marked with a radiograph marker. In cases of an intra-articular injury, CT imaging should be performed in the involved extremity in order to determine the extent of articular communication and guide future surgical reconstructive interventions. The treating surgeon should be considered that the settings of damage control orthopedics blind CT on an intra-articular fracture until after reduction and the temporary stabilization might yield greater information for planning the definitive fixation procedure. Future more CT angiography of a formal angiogram may be indicated in case of suspected vascular injury. Antibiotics. Multiple studies have elaborated on the role of the early systematic antibiotic administration, wound debridement, and early soft tissue coverage, and decreased the risk of infection in high-energy orthopedic trauma. Low-velocity ballistic wounds not require operative stabilization may be treated by a short course of oral antibiotics and local wound care without and increase infection risks. In these injuries, severe combination of osseous defects occur typically from high-velocity ballistic injuries. Early systematic and local antibiotics should be considered. Antibiotic infringement, irreversible tears should be considered in wounds that can be definitely close to future later infection complication. Furthermore, in cases where large defects remain and future reconstructive procedures will be attempted, non-absorbable antibiotic carriers such as should be considered to allow the local bacterial control while providing the space management and future soft tissue healing. Typical negative pressure wound dressing without silver augmentation should be considered in all cases as the risk wounds to the assist with preparation in patients not ready for definitive management. Locally administered antibiotics via antibiotic beads and absorbable chitosan sponges or directly applied antibiotic powders should be also considered to future augment negative pressure from the temperature, and the will have been shown to effectively decrease local bacteria and contaminated wounds. While the first generation cephalosporin is commonly recommended for ballistic injury, special consideration should be given in the management of fracture with the concomitant bowel injury, as the literature suggests that the use of broad-spectrum antibiotics administered for 48-72 hours are optimal of minimizing the risk of infection. Initial surgical management. It is important to note that not all ballistic injuries require operative stabilization of bony reconstructions. The literature has demonstrated that low-velocity ballistic injuries can be safety management with local debridement and irrigation tetanus prophylaxis when they require an antibiotics followed by splitting or casting, as long as an adequate reduction can be obtained and maintained. However, those fractures caused by low-velocity ballistic injuries that are unstable or those reductions can be maintained, they can often safely by management with acute definite operative fixation and stabilization of patient fractures alone. In a patient in extremity, the principles of damage control orthopedics should be followed, and temporal stabilization via external fixation performed with the considerance of future operative plans. Studies have shown that definitive intramedullary nailing and open reduction and internal fixation can occur in the settings of several open lower extremity fractures without an increase in infection rates, provided concurrent wounds are closed or covered with reliable soft tissue. As such, a soft tissue attempts should be made to definitively stabilize the fractures. In these cases, where soft tissues, tendons, repeated debridement and irrigation is indicated of soft tissue coverage is required and external fixation is often applied that can be later considered definitive fixation. Dead space management can be obtained using non-absorbable antibiotic cures such as maybe soft tissue approximation should proceed as soft tissue allowed using monofilament sutures, negative pressure wound dressing, progressive soft tissue closure techniques, and negative pressure wound therapy can assist with non-possible of at-risk wounds. The surgeon should be maintained allowed their shoulder to perform fasciotomies in high-energy ballistic or blast injuries as compartment syndrome is well documented complication. Furthermore, in the settings of a vascular insult or prolonged tourniquet times, fasciotomy should be considered due to the concern for reperfusion into induced compartment syndrome. When performed, fasciotomies should be progressive, close, or grafted with split thickness skin graft. Dermal substantiation and a cellular dermal matrix can future assist in cases of exposed tendons or bone structures prior to skin grafting with the future. Soft tissue coverage can resemble a cube. Definitive fixation. When discussing management of the high-velocity ballistic injury to an extremity, it is important to consider the tenets of the limb salvage procedures. Internal fixation should only occur in the time of the after the soft tissue wounds have been closed or covered. Implants should never be used of wound closure is not possible. Definitive fixation can only occur in the patient and the limb have been appropriately prepared. Resuscitation of the patient, physiological stabilization is required, or this cannot be achieved due to the extent of the injury. Amputation should be considered. A resuscitation of the wound throughout irrigation and debridement, stabilization of the bone and liberal as of fasciotomy when indicated. Secondary management, assessment of the wound with continued debridement of non-available tissue. There is continued phase of prevention of infection to include the management of soft tissue defects and dead space management throughout each subsequent operative intervention. The patients should be non-step closer to definitive reconstruction. Definitive management, this period is marked by stabilization of the patient's general health status, as well as limb injury evolution. This definitive phase involves reconstructions of bone and soft tissue using a variety of techniques. It is important to note the observation with the isolated extremity injury from a low-velocity projective with the associated vascular injury may progress rapidly to definitive management of the patient bone and soft tissue and enable. There are three principles and methods of skeletal stabilization in the treatment of the ballistic injuries require operative stabilization, plates, interlocking nails, and external fixation. Plates can be applied to perform various functions such as compressive protection, buttress tension, bend, and briding. Depending on the techniques used, the plates can function to provide either absolutely or relative fracture stability due to advances in modern nailing, open reduction, and internal fixation, with traditional plating systems is commonly reserved for upper extremity fractures and periarticular fractures on the lower extremity. Plates are commonly used to the management of upper extremity fractures due to the need to obtain anatomical reductions, radius, and ulnar fractures. They also have an advantage of providing optimal fixation for very short proximal or distal bone fractures, periarticular injuries, where intramedullary implants may not be able to provide adequate fixation. Throughout traditional plates, osteosynthesis are significant. Surgical exposure is often required to anatomically reduce and stabilization of the bone. Variations to these approaches, such as minimally invisible approach, can be used to minimize to the soft tissue injury using traditional approach. Furthermore, due to the degree of soft injury and the soft of injury sustained from high energy ballistic trauma, unconventional surgical exposures may be required to allow for appropriate debridement and irrigation and successful fracture fixation. Standard surgical exposures can be used for low-velocity ballistic fractures when surgical debridement and irrigation of the protective path of the cavity is not necessary. In high-velocity injuries where surgical debridement and irrigation is recommended, the wounds are extended to allow thorough debridement of all non-available tissue. Since these wounds are often too along traditional surgical soft tissue plans, they may necessitate alternative surgical approaches as to not cause future of the soft tissue damage. While many ballistic injuries are amenable to compression, plating, and absolute stability, which allows primary bone healing, injuries with extensive communication of bone loss may require breech plating. The duplication of the breech plate spins the comminution of area of bone loss, creating a relative stability construct which will help throughout secondary bone healing and subsequent callus formation. Intermediary nails. Modern intermediary nails have the significant advantages of offering satisfactory biomechanical stability to allow early weight by bearing. In addition, the ability of the often all early is not immediate. A wide bearing following fixation with an intermediary nail, these intermediary implants are also ideal for the management of tibial fractures, where light union is more common. Intermediary nails offer several additional benefits. It's a familiar technique to the most orthopedic surgeons and minimize soft tissue dissections, which can be beneficial in extremity that already has a significant amount of soft tissue injury due to the ballistic injury. One concept of the use of intermediary nail in the settings of ballistic or open fractures is the risk of infections and difficulty treating it should not occur with an intermediary implant. However, the literature suggests that they can be safely used in these injuries. Also, the severity of injury increased, so does the risk of infections. Lower velocity injuries require operative stabilization. Enabled to intermediary nail, the fractures can be treated similar to a close injury without the need for surgical debridement and irrigation of the soft tissue wound. For higher velocity injuries, surgical debridement and irrigation should be performed of the wound, which is often followed with temporary external fixation depending on the extent of the soft tissue injuries. Definitive fixation can occur once of the soft tissue are amenable. External fixation is very versatile and you can provide repeat and the safe stabilization of several of fractions, whether from high velocity and lower velocity ballistic injuries. They can be used reserving length and alignment and can provide adequate bone stability with long access to the wound for vascular or plastic surgeries of need. The goal of temporary external fixation is retrospectivity of length and general alignment without concern of achieving anatomical reduction. It avoids an unnecessary trauma of the tissue and can be performed repeatedly. When placing a temporary external fixation, it is important to try and keep shanks health pins out of zone injury and, when possible, distant to the plane definitive fixation. However, pin plate overlap has not been demonstrated in the literature to increase the risk of infection due to decreased stability with unplanar frames. Wrench fixation is commonly used for definitive management in an external fixation. Good results have been achieved using this method in the management of several open tibial fractures to both the military and civilian settings. When temporary external fixation is used, is ideal to convert to the definitive methods of fixation within 2 weeks if you use in place or an intermediary nail in order to decrease complication and infection rates. An additional benefit to the use of fringe external fixation is the ability to manage both of the bone and soft tissue injuries. For injuries that have been segmental, bone and soft tissue lost, an acute shortening or shortening in angulation can be performed. In all the case, the link can be performed of the fracture size to achieve wound closure. If the segmental bones and soft tissue loss to include a neurovascular injury, the limb can be shortened to allow and repair in the neurovascular structures. Once epithelial healing beans length can be restored through destruction of osteogenesis via distant corticotomy. When performance this procedure is taken to ensure adequate limb perfusion is managed throughout the process with the use of Doppler, and the change in the quantity or quality of the surgical requires modification followed by resistance of the surgeon. Special consideration: bone losses. Bone losses can occur accurately following ballistic injuries, particularly in the settings of a high-velocity injury. It can also occur as a result of the complication following in the initial management of these injuries. For example, if a patient develops an infected, non-human infected or non-valuable bone may need to be debrided, resulting additional treatment stretched because they will not heal independently, commonly referred to as segment defects. They are frequently managed by the following two methods: muscular techniques, induced membranes, and distraction osteogenesis. Muscular technique. In patients with segmental defects and stable fracture following fixation, the defected infile the PMMA typically loaded with antibiotic to help minimize the risk of infections. For 20 weeks later, the membrane is incised and PMMA is removed. The time for performing the bone grafting and important. Historically, it was done between 10 and 12 weeks after initial placement of the pineal spacer. However, recent evidence suggests that the growth factors within the induced membranes that forms around the pineal spacer and our optimal levels at the 4 weeks. Care is taken to not disrupt the membranes that is formed around the PMMA other than enough to remove the PMMA. The bone ends are prepared and ensure that they remain available with healthy bone bleeding, and autograft is placed within the defect and the wound is closed. The choice of the autograft is up to the treating surgeons, and there are many options to consider, including the iliac crest, the femoral canal, via use of primary irrigation aspiration of the proximal tibia. Currently of bone require location of the defect, and the surgeon's experience all factors can be influence the choice. Alternatively, allograft bone graft and bone graft stability substitutions can be used, but autograft is considered to the gold standard. As a result, the commonly used as bone graft extends the rather than is isolation. Distraction osteogenesis. Distraction osteogenesis refers to the tension stress model where slow steady stress or in case distraction causes the bone and soft tissue to become metabolically active, which results of controlled bone graft. In order to perform distraction osteogenesis, an implant must be used that can also grow. This commonly include rigid or monolateral real external fixations. In the settings of segmental defects, the fixator is required to stabilize the limb. A distant corticotomy is performed usually in the metadiaphyseal region of the bone due to the regenerative characteristic of this region. After a short latency period, the segments where the corticotomy was performed is lengthened at a rate of 1 millimeter per day, and the segments where the defects is located is shortened at the same rate. As a result, as the defects is closed, as new bone and soft tissue are regenerated at the distant site. This continues until the defect is closed and the limb length has been restored. If an acute shortening was performed initial where bony contact is achieved without the segmental defect, then the distant site is distracted until limb length is restored. This where was shortened and our angulation performed, the deformity can be corrected gradually throughout to the use of rigid external fixation on soft tissue healing occurs, followed by lengthened if required. Conclusion. There is wide spectrum of the bone and soft tissue damage can be occur as a result of ballistic injuries. It is important to treat each one individually. The treatment may be very dependent on multiple factors, the most important being the patient's physiologic status. For the definitive management of fracture, the variable techniques as possible. The choice of the one techniques or the other depends to the individual surgeon clinical experience and technical experience. Okay, that's all. All students, goodbye.
До свидания.